Lina and Rada's show. How are you doing, guys? Hope you're doing well. So today we are recording a session for you. As you know, things are a bit tricky here in Melbourne, Victoria, as we don't know if we're going to a full lockdown. So we thought that we still want to provide you some information about TG. So we are now recording this session for you.
Yeah, last week we spoke a little bit about the first chapters of TG with the recent changes. And for this particular week, we plan to talk about oral mucosal diseases. And like Rada said, we are just anticipating every possible, stage 4 lockdown here in Melbourne. So that's why we wanted to record this session for you guys today.
So hope you'll enjoy it, and let's start.
Yes, definitely. Okay, so same way that we did 2 weeks ago. And we are going to have here old TG and new TG. So I wonder that you guys are asking yourself, who's going to answer all the questions that this topic is going to arise? And what we are trying to do is when this video gets posted online, we are going to be at the same time watching the video with you guys. So you can ask questions on the comment boxes, and we are going to be able to answer those questions. So we are trying to manage the entire situation in order to be able to provide you with some answers to your queries.
Exactly. So today we are going to do the oral mucosal disease.
Yep.
So we'll go through like last time, through the entire or half chapter, because this one is a bit long.
Yeah, this one is long.
We might split it into two. So the changes, Lina.
Yeah. Well, first of all, basically the first part of the chapter, or the third page, if you refer to the new TG in page 93, you will see the assessment of mucosal diseases. But I think in the next page, there's something quite important for everyone to know by heart, basically, which is the box number 12 that refers to red flag features of oral mucosal disease. So I think you guys need to keep that in mind, because if we are taking this to an OSCE context, we need to know that this information needs to be included in our taking history, for example, if the context of the OSCE as well requires that we apply what is written here. So regarding the red flag features, Rada, what do you see in there that is particularly important?
So first thing that we could read is that compared to the OTG, so now if you have an oral ulcer that lasts for more than 2 weeks, you have to refer. Instead of the OTG, it was 3 weeks.
Correct. And that's the first point.
Yeah.
Oral ulcers that have lasted for more than 2 weeks. That's a red flag.
Yes. Oral ulcers that recur. Non-traumatic ulcers in children, because in that case it will lead to a systemic disease. That's why it should raise awareness that we might have an underlying condition.
Correct.
Pigmented lesion on the oral mucosa, red, white or mixed red and white lesions from an unknown origin, because this could lead, you have high chance or risk to having oral cancer.
Yes, correct.
So you still need to ask about the induration. How is you have to check how are the margins, if there is a fixation to the underlying tissues, and if it is located on high risk sites like the lateral borders of the tongue, the floor of the mouth, for instance.
Yeah, basically what they are trying to say with this box is everything that is out of place, something that doesn't belong to the mouth, like any spot, vesicles, ulcers, anything that doesn't belong in the normal environment of the mouth, we should be able to assess it, asking the patient some questions. Obviously, you are going to say to us, how are we going to ask the patient if there's induration? Obviously, the patient doesn't know what induration is. But usually these cases, when you are going into the exam, you will see that they have some pictures. So you also have some reference pictures here in the UTG as well as in the OTG. So the idea is that you can, do a search to look how induration looks like in the mouth, so you can have an idea in case in the OSCE you get a picture that maybe refers to induration.
Or you can say that we took this picture and I still need to palpate this area, so I can have more information with this palpation.
Yeah,
for instance.
Definitely.
Paresthesia, oral or facial, should raise a red flag.
Correct.
Swelling, including lymphadenopathy. Any salivary gland issue, swelling, pain, blockage, that could suggest that you have a salivary gland disease. As we saw previously in the OTG, suspected allergy or an adverse reaction to any dental material like amalgam for oral lichenoid reaction, dry mouth, that is not relieved by any artificial salivary products. Or any method, like you remember this table for dry mouth, so you should seek for specialist advice. Dry mouth caused by systemic disease like children syndrome, any oral manifestation of a systemic like HIV or Behçet's or syphilis, although syphilis is quite rare nowadays, but we never know. Lichen planus, pemphigoid, and finally the lesions that occur in immunocompromised patients, like HIV infection or neutropenia, or immunocompromised patient like uncontrolled diabetes.
Yes.
You should
raise.
Yes, you should seek for a specialist advice in that case.
Yes.
All these cases.
Yeah, definitely. So I think also another thing that as candidates you need to be very smart is how you bring all of this technical information that we are reading here into a real context of a simulation with a patient. Because with a patient, we are not going to speak in these exact same words, but we need to be smart enough to try to take that information out of the patient, which in this case is an examiner simulating being a patient, but in a manner that is so understandable for everyone that the examiner knows that you are able to communicate this type of concerns with a real patient. Also, without creating, panic. It's not like we are going to start telling straight away to the patient that, oh, you are meeting some red flags here, so you probably have cancer or stuff like that. Obviously, language, it's very important in OSCE cases. So more than knowing what's the difference between OL and UTG, it's also quite important for you that you are able to translate this in a very simple language. So the examiner, in a calm manner as well, to explain these things or to ask these things to the patient. I'm not saying either that all these, how many points, 10, 11 points, you need to ask them in a history taking. So you take, depending on the OSCE that you are seeing in that particular moment, you are going to refer to that box and you are going to start saying like, okay, so if the patient, it's already said to you that it's not immunocompromised and doesn't have any medical condition, don't ask that again, for example, just because it says here. You need to be practical and to apply the things that apply for that particular OSCE.
Exactly. And always open-ended questions that will help you. And then if you need a particular answer, or particular information, then you will ask a bit more in detail with the closed-ended question.
Yeah, definitely.
So here they added which conditions that won't require a specialist advice. So it's a good summary here in that page where you will be able to manage yourself.
Yeah, provided that these ones doesn't have any red flags.
Exactly. And so this might require an active treatment. So after ulcer, traumatic ulcer, geographic tongue, dry mouth, and so on.
Amalgam tattoo.
And the other causes that are more physiological, like Fordyce spots or leukodema, does not require an active management.
Yeah.
So these are the situation where you can deal as a general practitioner.
Yes, so that one that Rada just read is quite important because you need to combine your possible differential diagnosis with the existing red flags, or doesn't, if red flag doesn't exist, fair enough, but you need to discriminate all of that in order to give the best advice in the OSCE station that you are going to get.
So in the new TG, they added quite few more example of oral disease.
Yes.
Mucosal disease. So they have added in the oral cancer chapter. We have
in that particular part of oral cancer,
there is more information.
There are more information
and pictures.
And pictures, you know, that can show you the different ways that you know, you can probably see an squamous cell carcinoma, because they know that it's tricky that by a photo you are going to be able to reach to a pretty accurate differential diagnosis.
And they don't ask you to give anyway a diagnosis because it's not your job. Yeah. It is the specialist job, the oral medicine, after doing a biopsy. So even the specialist, I don't reckon that they are giving straight away a diagnosis. They are first investigating and then they give a accurate diagnosis.
Correct.
So we have in this chapter oral erythroplakia.
That's new.
Yeah, that's new. HPV. We have a small chapter all by itself, oral lichenoid lesion. And amalgam tattoo, hairy tongue, traumatic ulcer, and that's it.
That's pretty much what is new.
Yeah.
So we can just revise which new things are in this particular condition. For example, for oral leukoplakia, pretty much what you see in this new TG is pretty much what is written on the old TG as well. So there's not too much difference in there. They are just raising awareness of the potential malignant transformation that oral leukoplakia has, and that you need to be aware of that. They are providing a photo here just for you to have a reference. Basically, everything that doesn't belong to a particular area of the mouth, you need to be able to discriminate what that is. And when you see an oral leukoplakia, basically it's described here as a clinical term for a white lesion that is not easily recognizable. So again, they are saying, look, we are going to find things that I'm not able to, you know, point a name on it, and you are going to be telling the patient what are your suspects, you know, like what is it that I think it is, and referring to the appropriate specialist. Which here, and we were discussing this earlier, Rada, because sometimes we have the questions of, as general practitioners, should I be the one to do a biopsy?
I always learned that if you announce a diagnosis, you have to manage the situation, the condition, which is not the case when we encounter like a potential malignant lesions. And here they added that if you are in a rural or remote area where you don't have a specialist review available or soon, because you know that in these cases it's quite urgent because we don't know the malignancy, the potential malignancy. So you need to be trained on doing a biopsy, but other than that, you should not, as a general practitioner, do any biopsy. You should refer to a specialist.
Yeah, it's also written here that the treating specialist should be perform the biopsy of an oral mucosal lesion. So here they are pretty much saying, if you are referring to a specialist, in this case our oral medicine specialist, that specialist is the one who's going to perform the biopsy on this particular patient. Basically, your role as a general dentist is to provide guidance to the patient, because the patient doesn't know that that white spot doesn't belong to the mouth. We know that because we are experts in the oral environment, but what we need to do is to raise awareness to the patient. I'm seeing something that doesn't belong there. With all the information that I have, I cannot reach a conclusion. Therefore, the best course of action is to refer you to an oral medicine specialist, so the specialist can perform a biopsy and clear all doubts. And then the patient, I guess it will be back to you for you to do follow-ups, or depending on the specialist advice.
So they added, as I said, oral erythroplakia. Basically, it's a red lesion that usually is asymptomatic and isolated. You will find it more commonly on the floor of the mouth, tongue, soft palate, and buccal mucosa. So it can have different aspects. It could be smooth, velvety, granular, or nodular, but you have often clear margins. So as you can see, so in the beginning of the oral cancer paragraph, chapter, page 95, they gave you all the risk factors, so the age, the gender, and so on. So here it's the same. You have also to think about all the risk factors, and one of the risk factors is that it can affect middle-aged or advanced age male. So here again, you have to refer to specialists. Basically, any lesion that doesn't look good, or sometimes it can be small but deep, then something unusual you refer.
Because it says here that approximately 70 to 90% of oral liquidation lesions are carcinoma in situ or squamous cell carcinoma. So that's quite important.
It's serious.
It is very serious. So, and remember that as a routine, as dentists, we should do our oral mucosal screening every time we're seeing a patient, even for the first time or a recall patient, because it's quite important to spot things that look out of place.
Exactly. Now, HPV. So, this virus is transmitted by direct contact with the lesion.
Okay.
And it can be sexually transmitted. So basically oral sex.
Yep.
So it looks like a kind of raspberry. It has kind of a raspberry aspect.
A small finger-like projections.
Yes.
Per TG.
And it is now recognized as one cause of a squamous cell carcinoma, particularly if we see it on the posterior tongue or tonsillar region or oropharynx, so posterior sites in the mouth. So again, this is a red flag, especially if the patient is also like always drinking alcohol, smoking, then again refer to the specialist for biopsy and management. Oral lichen planus. So what have changed is that first of all, the symptoms include stinging, burning, especially with spicy or acidic food. So we were talking about geographic tongue because it's written that it typically occurs on the buccal mucosa, tongue, and gingiva. But if it occurs on the buccal mucosa and tongue, likewise,
like
geographic tongue, so what will be the difference will be the clinical aspect of the lesion. So you will have to ask the patient, for instance, have you noticed that this plaque, white plaque, red plaque, are moving from time to time?
Clinical history.
Clinical history, very important. So you can do
Family
the
history. Yeah.
differential diagnosis between lichen planus and geographic tongue if you have a tongue lesion and spicy or acidic food pain or sensitivity.
Mm-hmm.
The other thing that we spotted is that
No, I think that
that's it.
That's it. I think the new thing about oral lichen planus is that you need to take into account what Brada just said. If the patient says that it has a burning sensation, stinging, with any type of particular foods, that could be coinciding with something that a geographic tongue patient can tell you. So clinical appearance, because we know that oral lichen planus looks different than a geographic tongue, because the classic, striate pattern that this has could be, and also a clinical history is going to be quite important. But apart from that, what is written here in this part of the chapter is
the rest
that
is the same.
Yes.
Like you have to do a biopsy
Exactly.
to confirm. Then you can prescribe, but again, biopsy it will be done by the specialist.
Yeah, that's pretty much it.
Then
We have oral lichen lesion.
so they have given one picture on the top for oral lichen planus, and the second one for lichenoid lesion, which was not in the OTG. So they have given for oral lichenoid lesion a bit more details about what could cause it. So you just have to go through it. Medical condition they have added.
Yes.
Hypersensitivity to drugs. So they have listed a bit more medication than the previous edition of TG.
And something that caught my attention was the thyroid disorders medications. From my experience practicing in Australia, there's quite a bit of people going under treatment for thyroid disorders. So that should be always on your mind, because again, we should be doing oral mucosal screening in every single one of our patients, and when we are trying to match the clinical history or the medical history with the patient and the medication that the patient is taking, we know what should we looking for when we are doing the examination.
Other than that, for oral lichenoid lesion, so what we spotted is that in case of contact hypersensitivity to an amalgam filling, first, when we have the oral lichenoid lesion, we have to refer the patient to a specialist so he can give us a diagnosis.
Correct.
And if we suspect that this is the amalgam filling that is producing this condition, then we can replace it.
Yes.
So first, we do a referral to the specialist, we confirm the diagnosis, and when we confirm that it is a lichenoid reaction, and then we think that it is linked to the proximity with an amalgam, then we remove the amalgam filling. Because before in OTG we just remove the amalgam and we follow up if it is
resolving or not.
Yeah, but this can take a long time to
you
resolve.
Never know.
Maybe months or year. So because we want to make sure that we are not missing something serious,
true.
then it is best to first give have a diagnosis, definitive diagnosis from the specialist, and then we do an active treatment.
Yeah, definitely. Here is more explicit.
Yes.
Because the other one doesn't say precisely that you are going to refer in order to rule out lichen planus. Exactly. So in this one, they are being very explicit. They said refer patients with a suspected oral lichen lesion to an appropriate specialist for definitive diagnosis and management. So that specialist is going to tell you this is the diagnosis and this is what we should be doing. And if that implies that you need to remove a particular amalgam, then you go ahead and do it.
And even here they say replacement of the implicated amalgam filling may result in partial or full resolution of the lesion. So this means that it's not compulsory that we have a full resolution of the when we remove the amalgam filling, but at least because we had this biopsy, we confirmed the diagnosis, then we know that it's not something that is serious, because as you know, like in adhesion and like in planus, it's similar. Geographic tongue, it looks pretty much the same.
Yep.
Management, same.
Sorry, Rana. The only things that are included in here,
red flags.
It's always come back to the red flag. Always come back to the red flags. So you can actually be sure that yes, this is not something to worry about. So that needs to be in your mind at all times when you are doing OSCEs. Yep.
So amalgam tattoo, it's something new. It's basically an oral discoloration because of amalgam residual.
Yep.
So what you can do is first find if there is any amalgam in the venicity, and or a previous amalgam as well.
Yep.
Then they ask if you want to confirm the diagnosis, you can take an X-ray. You may find particles or not. So
yeah, we were discussing that it should be very difficult, to spot little particles of amalgam on an X-ray, because
unless it's a big one,
unless a chunk of amalgam, but otherwise it could look like an artifact, on the X-ray. It's going to be a little bit tricky, but they suggest here that you could take an X-ray in order to, make a differential diagnosis just in case. So I think that even though we practically think that that's going to be a little bit tricky, if you face a case about an amalgam tattoo, that's something that you need to read and try to incorporate in your speech. Like if you are saying to the examiner that what it looks like is an amalgam tattoo, so you will tell the examiner, you will ask the questions. If the amalgam is not there anymore, you will ask if the patient had a previous amalgam restoration near to that area, or if you are seeing it well enough. But also you will tell the patient that in order to clear doubts, maybe an X-ray could be something helpful just to try to spot any possible particles of amalgam in there.
And until the diagnosis is not confirmed, you don't find any red flags again, you have to refer to the specialist. And when it's confirmed, nothing to do, just correct diagnosis, reassurance.
Yeah.
This is what we
just remember that this one is included in the list that we read at the beginning.
Yes.
That it's included in those particular conditions that if they don't have any red flags, you can just monitor them and treat them if you need to treat them. Yeah. So amalgam tattoo is included in there.
Hairy tongue, it is quite similar to the OTG.
Mm-hmm.
They just specified a bit more about the sodium bicarbonate mouthwash.
Yep.
Just describing how you can use it. Other than that, nothing
much the same.
Yeah, nothing in particular. Traumatic ulcers, oral ulcers, so they are telling you about what could be the cause, so like just OTG.
Mm-hmm.
Any sharpness, hot food, a broken tooth, a broken restoration, toothbrushing, the trauma from a toothbrush. Any appliance like ortho appliance or chemical burn, like the incorrect use of tooth bleaching products. So this is they added tooth bleaching products.
And they have also said that like something to treat the discomfort that sometimes a traumatic ulcer causes is the salty water mouthwash. This is pretty standard, but also they have suggested the benzylamine 1% gel that the patient can use just to relieve discomfort. Obviously, this need to be clear that if you don't suspect anything else, then you go ahead and try to treat the discomfort with that. But again, they are saying here that any persistent ulcer, more than 2 weeks, which is a difference from OTG, we already said it, we should refer the patient to a specialist.
Or if it recurs.
Or if recurs, yeah. Yeah.
After ulcer, so the beginning is quite similar. They describe the different types of afters: minor, major, and the herpetiform. Then they provide you a list. It's clear.
Yeah.
It's more better organized.
Yeah, but it's pretty much the same.
Yeah. The thing that we noticed about the management is the use of hydrocortisone 1% cream or ointment, and in the OTG it was
the
betamethasone.
propionate.
So it means that this one is the mildest form of corticosteroid that we can use. They also added the benzidamine 1% gel, so to relieve the pain, and they added the lidocaine 2% viscous solution, again to provide some pain relief. So again, any ulcers that is not improving after 2 weeks is potentially malignant, so we need to refer for a biopsy to have a accurate biopsy diagnosis. Major form, herpetiform, or immunocompromised patient, you need to refer.
Yeah. So basically, everything goes back to how good you can take your history for the patient.
Exactly.
So remember that we have 3 clusters in the exam. So we have information gathering, we have diagnosis and management, and we also have clinical treatment and evaluation. So depending in which cluster are you in, you need to direct your questions so you are able to fulfill the purpose of the OSCE.
Now herpes. Basically, the explanation of the disease is pretty similar
pretty
to
much the same. Yeah.
the beginning. The treatment, they clearly added benzidamine 1% gel for a topical relief of pain.
In the OTG they mentioned
with
chlorhexidine. Here they are not explicit about chlorhexidine.
Yeah.
So I think we are not sure if that's because of a particular reason that they don't want to prescribe chlorhexidine for these patients.
But we don't. I mean, there is no bad if we add chlorhexidine, since the patient, if he has a severe primary, not a severe, moderate, mild to moderate, he cannot brush his teeth efficiently, chlorhexidine will just lower the load of germs, so there is no harm, I think. Then they again added lidocaine viscous solution for a topical pain relief, so they have added a more detail regarding the age, and they have added if the pharynx is affecting adults or children more than 12 years old, then the patient can gargle and swallow the solution.
Correct.
If there is any severe presentation, immunocompromised patient, then you can refer to hospital or medical practitioner, but I guess a hospital is maybe the best solution.
Yep.
So now, regarding the recurrent herpes, so they describe just as OTG. The thing that they are saying is that we no longer do a microbiological testing, because most of the people are infected with that herpes. So if you want to do a diagnosis differential from afters or traumatic ulcer, you will always find DNA from the herpes virus. So it's not a reliable testing. They are saying that we don't do any swab of an afters or traumatic ulcer, because you will find always a DNA from the herpes virus. But your diagnosis should be based on the history, thorough history, and clinical examination.
Yeah.
And the other thing that they have added, a comparison with the OTG. Here you can give famciclovir for adults, 1,500 milligram orally as a single dose when we have the first sign or the prodromal stage, so it can be given orally instead of having only the acyclovir and panciclovir.
Yes, because I think OTG was only topical therapy.
Yes, exactly.
So this one in this one they are giving us the option of have a topical therapy with acyclovir, but in case you want to switch for a systemic therapy, you can just prescribe the famciclovir.
Exactly. And they just added a referral to the medical practitioner if we have severe recurrence of the herpes.
Yep.
If you have generalized or chronic herpes infection associated with crusted lesion and ulceration, and immunocompromised patient, as always. Yes, so we have finished one part of our
oral mucosal disease chapter.
Yeah.
Which I think at the beginning it could be like a little bit confusing, because here we are trying to compare old TG with new TG, but basically besides you worry that you need to memorize all these things, because some things you do need to memorize it, but it's good for you to start seeing the relationship that all these red flags mentioned in this first box in this chapter are impacting in all the different oral mucosal diseases, because everything that we do is if the red flag is present, if the patient is immunocompromised. So everything depends on the context.
Yes.
So it's not that I'm seeing herpes and I think that is herpes and I'm going and say the management, but do I take the history? Do I take any photos? Do I have any photos in there? So make sure that you are very conscious when you are reading this new TG, so you can more than establish difference with the old one. How are you going to apply this in a real scenario for an OSCE?
Exactly. So next time
we will continue
with the oral mucosal disease, because it's a long chapter, lots of things to
and
say.
we don't pretend to have all the answers, to be honest.
No.
We have been very thorough doing the reading of these, trying to inform us a little better about the changes and everything. Still, we probably don't know everything, but we are just trying to take all your questions, the ones that you are asking right now while the video is playing, and if we don't have the answer for a particular question, be sure that we are going to note that down, and we will get back to you guys and investigate a little bit more about what can we do to help you with that.
So we'll see you next time, hopefully live.
Yeah.
Otherwise will be recorded like this one. So see you soon. Bye-bye.
Bye.